Welcome to Easy Treatment Healthcare Private Limited, your bridge to global healthcare. At Easy Treatment, our mission is to be your preferred healthcare partner, providing personalized and comprehensive medical assistance to patients worldwide. Our vision is to be a global leader in medical tourism, known for our commitment to quality, compassion, and excellence in patient care. At Easy Treatment, we cater to all patients, ensuring a seamless healthcare journey regardless of your location or background. Start with a simple inquiry. Contact. Visit our website for an initial consultation, where we'll understand your medical needs, preferences, and budget. We conduct a thorough assessment of your condition, discuss available options, and assist in scheduling appointments with top-notch healthcare providers in Hyderabad. Our dedicated team will accompany you to hospital visits, ensuring smooth communication with healthcare professionals. We provide continuous support throughout your treatment, from follow-ups to medication assistance. Even after your treatment, we're with you every step of the way. From post-treatment care to coordination of follow-up appointments, we've got you covered. Our comprehensive services include medical tourism, free medical assistance, appointment scheduling, medication and investigation support, second opinion services, and budget-friendly hospital selection. Our exclusive services includes organ transplant, joint replacement, robotic surgeries, neurosurgeries, heart and cancer treatments. For our NRI patients with parents in India, we go the extra mile. We support in carrying them to the hospital and ensure their safe return home. We welcome your loved ones with open arms, offering arrival support, airport transfers, and initial orientation. Experience hassle-free healthcare with Easy Treatment Healthcare Private Limited. Your journey to wellness begins with us. Contact us today at.
Good morning all. My name is Karishma and welcome you on behalf of Easy Treatment Healthcare. Today, we are hosting a Preventing Early Heart Attacks in the Easy Treatment Ask the Doc webinar series. I would again like to welcome everyone who is present today. Easy Treatment is a medical assistant organization dedicated to helping individuals with any health issue. We seek to provide a clear understanding of health problems, answer your questions, provide quick access to doctor support, and manage your treatment from beginning to conclusion and post-treatment as well. We extend a warm welcome to Dr. Anup Agarwal, and we feel honored to have him to present this webinar. Dr. Anup Agarwal, with over 16 years of experience in a renowned senior consultant, interventional cardiology, specialized in transcatheter aortic valve replacement. After the presentation, there will be an opportunity for all of you can ask questions about the insights shared. So feel free to participate and make this webinar more interactive. So doctor, please continue.
Thank you so much for the introduction and good morning to all of you. I hope my voice is quite clear to all of you. Can someone please confirm if I'm audible?
Yes, sir.
Okay.
Yes,
right.
sir, you are audible.
Okay. Just bear with me while I figure out how to share my slides in just a second. I got it. Okay. Are my slides visible to all of you? Again, if somebody can verify.
Yes, yes.
Okay, all right. So again, thank you all for inviting me for this very important and very relevant discussion on human health. And the topic for today is preventing heart attacks in early stage. And at the offset, what I would like to point out is a lot of diseases that we get have some component of age-related degeneration also, something like knee arthritis or memory issues or hair fall, and for that matter, even blockages in the heart. So if we live long enough, then a lot of us will develop blockages in the heart. So if, let's say, there is a person in his age of 80s and 90s, there is high likelihood that we will find some blockages in his heart or her heart. Those blockages won't be classified as early heart attacks, because we expect that as we age, our body it kind of goes through a wear and tear process, and just like our joints, they wear out, just like our memory veins. Similarly, our arteries, which supply blood to the heart and to other parts of the body, they also kind of face a lot of these wear and tear, which can lead to blockages and whatnot. So today's is mostly on looking at blockages which happen at early age. Early age means what you hear in age 30s and age 40s. These blockages, they are not expected to happen. This is what we classify as early heart disease or early heart attack. And this is definitely something that we should focus upon, trying to prevent as much as possible. And if unfortunately some event does occur, then we need to be very facile in treating those problems, identifying them early, and so forth. Because needless to say, heart blockages and heart disease, they are quite detrimental. And in some situations, they can be lethal also. Even the first event itself can be lethal. So with that introduction, let me start and very basic of what is a heart attack. And I think this part is quite easy to understand for people, but there could be some confusion around it. So to put it very simply, a heart attack is supposed to occur when there is a complete blockage or occlusion of blood flow in one of the heart arteries. So what ends up happening is, let's say you have an artery. An artery is basically a conduit which carries blood. In medical term, we call it artery. Let's say an artery which is carrying blood to some part of the heart, because every organ in our body, it requires blood, it requires food, oxygen, and whatnot to survive. And these arteries, they, via blood, carry all those nutrients and essentialities. So let's say if one of those arteries that is supplying blood to the heart starts getting these fat cells deposited onto it, and with that, some other healing mechanism starts. But what ends up happening is you get a very small early blockage formed in the artery. Now, those smaller blockages, they are not causing a heart attack, at least at that point of time, because even when the blockages are present, there is enough space in that artery where the blood can flow. Until the time the blood is flowing reasonably well and it is supplying blood to the heart, that part of the heart will not die, aka you won't have a heart attack. You will have a blockage, but not a heart attack. But there will be a situation where the blockages will become very severe. Very severe means 80%, 90%, or 100% stenosis or blockages, which means now the blood flow is severely compromised or occluded or not going at all to that part of the heart. When that happens, that part of the heart muscle won't get oxygen, won't get nutrients and whatnot, and they will start dying. So heart attack is a problem of heart muscle, where the heart muscle starts dying. Blockages, on the other hand, is a problem of the arteries. But because of blockages, heart attack occur. So they both are, while they are two different entities, they are related to each other. It is the blockages which eventually will lead to heart attack. So if somebody already had a heart attack, that means we are dealing with not one but two problems. One is heart attack, that is muscle damage. And second, blockage, because if there is muscle damage, there has to be a blockage. That is why the muscle got damaged. So in our colloquial term, when we say heart attack, we mean basically that there is at least one vessel which is severely narrowed, 80, 90%, 100%, leading to damage to the heart muscle. So that, in a sense, what a heart attack would be. Now, we all think that, hey, if I have blockage, I will feel the problem. Well, you won't. And as I was explaining, unless the blockage is severe enough that it causes interruption or restriction of blood flow to the muscle, your heart won't cry for help, because your heart is getting enough blood that it requires. So if your heart doesn't cry for help, you won't feel any pain, you won't feel any discomfort. So there would be patients with blockages of 40%, 50%, 60%, but it is not restricting or it is not causing any interruption in blood flow to the heart. Till that moment, a person will not feel any symptoms. All the tests, everything that you do will become normal because that blockage is not causing any problem yet. So the only way you'll be able to see that blockage is if you do an angiogram or some other test. But usually relying upon symptoms or relying upon screening tests like ECG and echo, you won't see anything because there is no damage happening to the heart. You cannot feel the blockage, you feel the damage. So if there is no damage, there is no symptoms. Few myths about the heart attack. Do blood donation affect the heart? Not really. You can do blood donation. That should not be a problem. Now, if your hemoglobin is low, or because of periodic blood donation, if your hemoglobin goes down, well, then it can affect the heart because hemoglobin is the one that carries blood. Secondly, if you do have an underlying heart problem, you may be knowing about it, you may not be knowing about it. But if you have an underlying heart problem, and if you give blood donation, that means you are losing about 200 to 300 milliliters of blood at a time. That kind of blood loss can trigger heart problem. So it won't cause a heart problem, but those people who already have a heart problem underlying, it may trigger a new problem. That is why patients with established heart disease, we advise them not to do blood donations. Another myth is heart disease is really a man's problem. Well, not really. There is certain truth about it. And by the way, when we are talking about heart disease here, we are only talking about blockages. There could be other heart diseases also. We are here only focusing on blockages, that too, which occur early in the age. We are not talking about blockages that happen at age 75, 80 or whatnot, because that could be age-related also. So in our young age, by that I mean 30s and 40s, in women, the estrogen and progesterone hormone, which only women have, which men doesn't have. So estrogen and progesterone hormones, they are a little bit protective towards blockages. So it is uncommon to see females in their age 30s and 40s to have heart blockages unless they have an underlying risk factor like diabetes or if they are smoking or whatnot. If they don't have any underlying risk factors, it is highly, highly uncommon to see early heart diseases in women, particularly in age 30s and 40s. So yes, at that age group, you would say if you see 100 heart attacks, probably more than 90 of them will be men. But once you cross 40s, once you are in 50s or 55, 60s and whatnot, when the estrogen and progesterone hormone level in women starts going down, then from the heart disease perspective, they both are pretty much the same. Similarly, those women who have got risk factor, which is diabetes or smoking or family history and whatnot, there also estrogen and progesterone protection will not help. Those women can also get blockages early in the age. Then the third myth is controlled diabetes won't cause heart disease. That is absolutely wrong. Diabetes leads to blockages in a time-dependent fashion, not in a control-dependent fashion, which means somebody who had diabetes going on for 10 years, even in those 10 years it was completely controlled, there is a high chance of developing heart blockages. On the other hand, if diabetes is not controlled, blockage will form even at 5 years or even at 3 years. But in a controlled diabetes patient, it is the time which has a legacy effect and which causes accumulative damage to the heart arteries and causes blockages. So just because your diabetes is controlled, that doesn't mean there won't be a heart disease. It possibly can. Diabetes remains a risk factor for the rest of the life. So can we detect blockages in advance? Absolutely, we can detect blockages in advance, but you won't detect that with ECG and echo, because ECG and echo or your routine blood investigations, they look at damage, they look at heart muscle. And as I was telling you, a 30, 40%, 50% blockage will not cause any damage or less likely to cause any damage. So unless there is no damage, unless there is no heart attack, your ECG and echo won't show anything. And for you to able to detect blockages which are not very severe, which has not caused any damage, if you intend to detect those blockages, then you can detect them by doing a CT scan or by doing angiogram or there are some other ways, other fancy stress tests which can be done, which can also detect blockages in advance. But those are special tests. In your routine screening investigation, you won't be able to detect blockages which are less than 70%. Pretty much not possible. Can we predict heart attack in advance? Well, yes and no. The reason why I wrote there yes and no is because if we were able to predict heart attack in every person, then people around us would never develop a heart attack. Our predictive algorithm is very good, but it is not perfect. Most of our predictive algorithm is based upon investigations, based upon the individual risk profile of the person, based upon their habits like smoking, alcohol, whatnot, based upon their existing diseases that they may have, based upon their family history, their lifestyle, their work, and all those things. So when we take all of these factors into account, we can reasonably predict that who is going to get an early heart attack, who is not going to get an early heart attack. While our predictive algorithms are very good, they are not perfect. So let's say even if we are 99% accurate, even if our predictive algorithm is 99% accurate, if 1% of India has to get a heart attack, that also will be lakhs of people getting heart attack. So when we talk in a population sense, then you occasionally hear stories where people developed heart attack when doctors or they themselves could not have predicted it. Those are very, very small fraction of them. In majority of the people, we are able to predict who is going to get a heart attack and who is not. And this is what I meant by risk factors. So on the left side of the chart, I have put in those factors which are non-modifiable. Like you can't really modify those. Age, like you will continue to grow. There is no way you can stop growing. Male gender, you can't change your gender, at least for most part. Family history, well, you are who you are. You can't change your family or your Indian ethnicity. Ambient pollution, to a certain extent, you really cannot change. Yes, you can control what is there inside your home, but you can't control what is outside your home. And similarly, food with poor nutrition. There is enough data now to suggest that the food that we eat these days are not as nutritious as what they were 100 years ago. And you only get that kind of food, the rice and the wheat and whatnot, they're pretty much the same. You're not growing out by yourself. So these things are something that you can't modify. On the other hand, the right side of the screen, there are a lot of things that you can modify. Smoking or tobacco use, diabetes, blood pressure, cholesterol, obesity, metabolic syndrome, which is a combination of few parameters, sedentary lifestyle, unhealthy diet, a lot of stress in the family, illegal or personal or professional use, illegal drug abuse, infections, and then there are some other rare causes. So a lot of these are considered as risk factors. So people, when they come to us, when we risk profile them, we mostly risk profile them based upon all of these. And as you can see, a lot of these data sets we can get simply by talking to the person and examining them. For some of the data set, you need investigations like cholesterol to define metabolic syndrome, to look for infections and other rare causes. Sometimes we require investigations for that. But for most part, based upon some preliminary data and interview and examination, we are able to risk profile a person in terms of where they fit. And that way we can tell them that you have this much chances of having a heart attack over the next 10 years. And if we identify patients or people who have got high risk of developing heart attack in the next 10 years, by high risk, medically we define as more than 10% in the next 10 years, then we start intervening. We start giving them therapy, medications, advice, and whatnot to reduce that risk of developing heart attack in the future. So in India, every second, about 10 people are either getting heart attack or dying of heart attack. That's very, very serious number. These numbers put us in the top 5 of heart attacks that happen in the entire world. And our numbers are growing, our numbers are increasing. So definitely this is a trend. This is a wrong trend that we are in. We need to reverse that trend. So the obvious question comes, how to detect blockages early and how to prevent heart attacks, or I should rather say early heart attacks. So this is kind of summarizing what we have discussed so far, that we do risk assessment, and a lot of it depends upon in-person interview. The kind of information that we get with interview, no amount of investigation can replace that. So it starts with the in-person interview. And then we do investigation-based risk assessment to add to our interview. And some of those are blood tests, some of them are basic CT scans, what we call it as calcium score. And then we do ECG echo to identify any established disease. Remember, ECG and echo will be abnormal only if damage has already occurred. If there is no damage, ECG echo will be normal. And then identify hidden blockages. There are indirect tests, that is treadmill test, all of you are aware of that. Then there can be stress echo or SPECT scan, which is called as single photon emission computed tomography. Essentially, it's kind of a nuclear medicine scan, very simple to do, similar to CT, if you may. And then there are direct scans, which is a CT scan, not the CT calcium score. That's a different thing. It's a direct CT scan where we look at angiogram of the heart, or we can do a conventional angiogram, which also tells us, identifies that hidden blockages which otherwise are not seen in ECG and echo. So when a person comes to us, we risk stratify them, and we put them into low risk, intermediate risk, or high risk category in terms of their chances of having heart attack in the next 10 years. And then those people who fall into high risk or kind of a high intermediate risk for future heart attack, in those patient subset, we start implementing risk modification strategy, where we have to intervene to reduce their risk to hopefully match that of general population. Remember, general population has about a risk. General population has a risk of about 4 to 5% heart attack every 10 years. Now, why general population has a little bit of risk? That is because of the non-modifiable factors that I told you, that you just can't stop aging, you can't just stop living. So a basic amount of risk always remains. It's like what I tell, the risk of having a traffic accident, even when your vehicle is in perfectly good shape and everybody is driving absolutely with rules being followed. Even then, there is a baseline risk of having accident. So there is a baseline risk of having heart disease or heart attack in general population, which is about 4 to 5% in 10 years. Or if you take it annually, that's about 0.5% per year. But we call it high risk when it is more than 1% per year or more than 10% in 10 years. So when we identify patients who are in that risk zone, we intervene with risk modification. And what is this risk modification? Well, certain lifestyle we want them to change. We want them to eat right. And in this talk, I can't really talk about the entire dietary assessment, but a basic idea is to avoid unhealthy oil, avoid too much mutton, simple carbohydrates. Again, they should be reduced to very minimal. And we need to stay fit. That means we need to look at our body mass index or BMI, and ideal being 18 to 25. So we should try to avoid obesity as much as possible. Then stay active. Remember, stay active doesn't mean staying fit. Those are two different things. You can be fit but not active. You can be active but not fit. So you need to be active, which means you need to do exercise. You need to do walking, jogging, whatever as per your age and as per your comfort. But a basic rule of thumb is any form of exercise where moderate intensity is included, we do that 150 minutes per week, or about half an hour per day with 2 days rest in a week. So something like that you can start your life. Obviously, stress management is very, very important in our day-to-day life, both personal as well as professional. And then we always advocate people to go for routine checkups. And by routine checkups, I do not mean investigations. I simply mean go for a routine checkup, meet a doctor, say hi, and let the doctor decide if you need any investigation, because it's very much possible that with your interview, a lot of the times you may not need any investigation, and that's pretty much, that's fine, that's absolutely okay. Quitting smoking is probably the most important aspect of risk modification if somebody smokes. And same thing is with controlling blood sugar and blood pressure. Remember, blood sugar is uncontrolled, heart disease will come early. If it is controlled, then it is a time factor. Then longer you are living with diabetes, more is the likelihood of having blockages. Same thing is with blood pressure. Then, of course, cholesterol targets, which are individualized based upon individual risk profile. And very rarely we put patients on blood thinners. If we think that the risk of heart attack is very high, and very high by that we mean more than 20% per 10 years, then sometimes we put those patients on blood thinners. Although these days we are avoiding putting blood thinners. These days, the data suggests that blood thinners have a role only in those patients with established blockages. But sometimes we do it for prevention also. That is very, very uncommon. So symptoms of heart attack, most of you know about it. The point here is that in about 50% of the patients, the symptoms may not be classic. And that is where you need to watch out for, and that is where you need to seek early help. So the two cardinal rules are: not everyone with a heart attack gets chest pain. This we discussed earlier. And not every chest pain is a heart attack. So just because somebody didn't have a chest pain, that doesn't mean there's no heart attack. Or just because somebody is having chest pain, that means there is heart attack. Both of the statements are wrong. We need to look at each one of them in more detail. The symptoms could be any sort of discomfort, anywhere from jaws all the way down to navel. Some patients have shoulder and upper arm difficulties. Some patients describe it as acidity, breathing difficulty, palpitations, dizziness. And few patients, they get silent heart attacks where they don't really have any obvious symptoms. But on the tests, you see that they had a heart attack in the test. So why are young people dying of heart attack? Well, the very first thing that I want to mention over there is when you hear the news about young people having cardiac arrest, one thing that we need to pay attention is cardiac arrest is not the same as heart attack. Cardiac arrest simply means heart is not beating. That simply means your car is not working, your car is not starting. Now, if your car is not starting, that doesn't necessarily mean that it is out of fuel. Your car couldn't be starting for other reasons. There could be engine problem, there could be wiring problem, there could be key problem, there could be transmission problem, there could be all those kind of problems. So when a heart stops beating, that doesn't necessarily mean it happened because of heart attack. It could be because of something else. It could be because the valves may have a problem. It could be because heart current had a problem. It doesn't have to be blockages in all the cases. While blockages are the most common cause of cardiac arrest, they are not the common cause of cardiac arrest in very young individuals. And very young individual means around 20 years of age or few years above and below. So if you hear a news of a 20-year-old guy getting cardiac arrest, there is overwhelming chance that it was not because of heart attack. That's probably because of something else. The only way we will know is by doing autopsy or a postmortem. So yeah, in the news, when you hear cardiac arrest, please look at if the news item mentions that whether it was because of heart attack. I hope I'm able to tell. Heart attack is when there is a plumbing problem. The tube or the artery, it gets blocked. And because of that, heart gets damaged. Now, the damage can be so severe that heart stops beating. And that is when you will call it cardiac arrest. In other terms, cardiac arrest is death. If a person is having cardiac arrest, that means that person is dead unless you revive them. Versus a heart attack patient doesn't have to, like a heart attack patient can be talking to you. A heart attack patient will be in distress, but he or she will be talking to you. Cardiac arrest patient is dead. So if you say that somebody I know had a cardiac arrest and he was talking to me, well, then that is incorrect. A cardiac arrest patient by definition means that person is dead unless you revive them with CPR or whatnot and all of that. So young people, lot of them, when they die of cardiac arrest, lot of time it is not because of heart attack. It is because of some other causes. But those people who do have heart attack at young age, they do. A lot of patients in my hospital and in our practice, we do see a lot of patients in their 20s and 30s coming with heart attack. So why these early heart attacks are there? Well, early blockages can form due to risk factors that I mentioned earlier. So if lifestyle is a problem, if stress is a problem, smoking is a problem, undiagnosed cholesterol is a problem, and all of those are a problem, then they can develop blockages early on. And some people, they have multiple risk factors, so they develop blockages early. A sense of pride of never going to the hospital. Well, I hear that very often. Never going to the hospital, a lot of the times people, they wear it as a proud badge. I would say that that's probably not a very good idea. While it is good not to get admitted to a hospital, it is good not to get unwarranted surgeries to you. But not going for a routine checkup or not going to at least meet a doctor and say, hi, doctor, just check me out and see if there is any problem. Not doing that is not necessarily a good thing. Because when you go to the hospital, when you go and meet a doctor, you give that doctor an opportunity to interview you, to look at your basic stance at that point of time, check your blood pressure, maybe check your cholesterol, maybe check for other things, maybe advise you one or two about your lifestyle and where you are doing it right, where you are doing it wrong. So all of these things, they are very, very instrumental for you to lead a healthy lifestyle ahead. So don't have a sense of pride that I have never been to a hospital. You don't need to go and get admitted or go for a surgery. No, just go and say hi to a doctor in their OPD and get a routine checkup done. And I'm re-emphasizing again, routine checkup doesn't mean getting investigations done. You get investigation as required. Just because you're not getting investigation, that doesn't mean you're doing anything wrong. Till the time you have met some doctor who has interviewed you and who has given a tailor-made advice which is appropriate for your body. The other problem that we see why younger people get heart attack is we often overcompensate. We overcompensate for bad habits with something good. Like, for example, let's say somebody is not eating right, but because they're not eating right, they over-exercise. They exercise too much, thinking that by doing more exercise than what normally I would, I will compensate for that bad dietary habit. That is not correct. Or let's say somebody who smokes. So they know smoking is bad. To counteract that, they are too much focusing on their diet and too much focusing on their exercise. No matter how much you do, the bad effects of smoking will accumulate. So just because you are overcompensating for one deficit, that won't take the deficit away. So when we are talking about exercise, we are, let's say, doing exercise for an hour, let's say. What are we doing for the next 23 hours also matters. So life is not just about that 1 hour or that half an hour that you are doing good to you. How do you lead your entire 24 hours? That defines your overall outcome, not that 1 hour. And then ignoring early signs of heart disease. Many of the times when the symptoms are not very classic, then we tend to ignore. Like, let's say somebody is having some acidity kind of symptom, and then you are taking antacids again and again, not realizing that it may very well be due to a heart problem, and you missed the early opportunity to get evaluated. And then now the next time the symptoms come in a very dramatic fashion, so much so that it causes a frank heart attack. So identifying early symptoms is also very important. So with this, I will close the discussion here. And I'm sure this is a topic where a lot of you will have general questions. So please feel free to engage in any kind of discussion. And you will have this easy treatment platform where you can communicate with and where you can associate with for your healthcare needs as and when required. So with this, I will take a pause, and if moderators can take in, and if there is any question, I'll be very happy to answer this. Thank you so much for your attention. Done.
Good morning, doctor.
Hi, good morning.
I have a question. That
Yeah, hi.
Always all the doctors or everybody will say smoking causes heart attack. But what about the chewing of tobaccos?
Right. So, any kind of tobacco product, it will cause what we call it as a vascular inflammation, which leads to development of these atherosclerosis or blockages and whatnot. So any kind of tobacco product will put you at a higher risk of developing blockages. Smoking is the worst of all, because when you burn a tobacco, then you release thousands of chemicals which otherwise were not there in raw tobacco. So raw tobacco is bad. Smoked tobacco is worse. If somebody says that chewing tobacco is not associated with heart disease, they are wrong. It is just that on a relative scale, smoking is much worse than chewing tobacco. But chewing tobacco has a problem with cancer and whatnot. So of course, that's another issue.
Good morning, doctor. Thank
Yeah,
you.
hi.
Hello, doctor. Just I have a small doctor. He told me, told that is avoid unhealthy oil. May you know what is unhealthy oil? Any?
Right. So, I did not elaborate on that because I thought maybe a dietitian would do a much better job with that. But since you asked that question, let's make a little bit, I'm trying to simplify it a little bit so that I don't talk for next 20 minutes on this. If you reheat your oil, that is bad. Let's just take that away. So you took your oil for cooking. Let's say you used it for frying something or whatnot and all of that. So that oil has already reached its maximal temperature. You let it cool down and then you reheat it and use it for some other cooking. Well, that is bad. The reason why that is bad is because every time when you heat oil, it transforms into what we call it as trans fat. And the trans fat is bad for heart. So any raw oil which is high in trans fat, like your vanaspati and whatnot, that is also bad for health. ACC/AHA would say that any oil which solidifies in room temperature, that is also bad. Now we know that ghee also solidifies at room temperature, and one may argue whether ghee is good or bad for health or not. But other types of oils, particularly coconut oil and whatnot, which solidifies, because the reason why they solidify is because they have a lot of saturated fat in them. So saturated fat content is bad. Trans fat content is bad. Reheating, which increases more trans fat, that is bad. Let us talk about what is good so that you kind of get a little bit of idea, and then more detail about it, maybe we can talk offline. Oil which has been produced without heating. So you will find refined oils and you will find virgin oils, or what we call it as cold press oils. Cold press oils have not gone through a process of heating, so they have much less trans fatty acid content. They are overall healthier. So you take any oil, let's say you take sunflower oil. Sunflower oil, you will find it as a refined oil, or you will find it as a cold pressed or a virgin oil. Cold pressed formulation is always better than refined oil. That is number one. Then number two, those which do not solidify, that is always better than those who solidify. Then number three, reheating, that makes even a good oil bad. So if you reheat, that is again not a good idea. Then quantity. A general rule of thumb is a person should consume 500 ml of oil per month. So let's say if you have a family of 4, and if your family is consuming more than 2 liters of oil per month of any formulation, ghee, oil, vanaspati, whatever, and all this, 500 ml per person per month. So I gave you a little brief about what is a good oil and what is a bad oil. And as I said, that we can go on and on this, but I hope I'm getting, at least I got some of the question answered from it.
Sorry, again, which is the proper age for anybody to have a full health checkup, full body health checkup?
So I would say no age. There is absolutely no age limit for it. Anybody who is an adult should go and get a doctor consultation. I wouldn't say go for a health checkup, as in go and get investigations done. Just go and say hi to a doctor, be it a physician, be it a cardiologist, be it whatnot. Let the doctor interview you. Let the doctor understand who you are, get your baseline established, and based upon who you are, he or she may be able to write a tailor-made prescription for you, which will be important for you. If you do not want to do that, if you want to go for a health checkup, then in an adult life, you should do it once every 5 years if you do not have any risk factors. If there is anybody in your family who had heart disease, then at least 10 years before that, it's absolutely must to get a workup done. So I gave you 3 different scenarios. Whichever fits with you, you can follow that.
And one more, sir, last question. Sorry. Nowadays, market now we are getting the vegetable oil, groundnut oil. So, is it advisable?
Yeah, so I would suggest that if you don't mind the taste of the oil, if you are not particular about the taste, then oil rotation is a very good strategy. So just so that I complete and I finish the oil discussion so we don't have it anymore, my recommendation would be, if you can afford it, cold press oils are slightly costlier. If you can afford it, go for cold press oil. Don't increase your limit by more than 500 ml per person per month. And every month, go for an oil rotation, which means this month you take a mixed vegetable oil, next month you take a groundnut oil, next month get a sesame seed, next month get peanut, next month get sunflower or something. Anything, unless you are particular about taste of an oil, if you do oil rotation, because that way you will get all the good things about the oil, go for cold press, don't reheat, limit 500 ml per person per month, you are done with that. I don't think for oil you need to rethink too much about it.
Thank you so much, doctor. Thank you.
Okay, I'm going to go through the chat box now, and you please feel free to write your questions on the chat. Once I'm done with the chat box, then I will also take voice questions. So one question which I got is COVID vaccine or COVID virus triggered heart attack? You know, this is a very, very debatable topic. While we saw some element of blood clots during the COVID times, we still do not have any conclusive medical data in support or in against of this finding. What I can tell you is, if COVID vaccine or COVID virus, if it caused heart attacks or blockages or blood clots, even if it caused, the incidence of that has to be less than 0.05%. It has to be less than 0.05%, because remember, both COVID virus and COVID vaccine, they both were a pandemic phenomena, which means every single adult in India either got exposed to COVID virus or got exposed to COVID vaccine. And even if you take an incidence of 0.05%, we would have seen lakhs and lakhs of people coming in here with heart attack, which we did not see. So we do not know whether it happens or not. And even if it happens, the incidence is so uncommon that I don't think it should deserve any kind of attention of any sorts. I believe that all other things that we do in our life has higher propensity of triggering heart attack or heart disease than COVID vaccine or COVID virus. So I'm not refuting that it didn't do it. The incidence most likely is very, very rare. I'm going to another question. How many days is CT angio and zero score reliable? Okay, so this question has been asked in medical community very commonly, which is, in other way, what was asked is, what is the warranty period of a normal CT angio? So truly speaking, the simple answer is there is absolutely no warranty for a CT angio. But if you do not have any other major risk factors for blockages, then a normal CT angiogram has almost negligible chance of having a heart attack for the next 2 years or so. So if I have to simplify it, I would say the warranty period would be 2 years, provided there is no existing major risk factors going on. And what I mean by that, let's say somebody smokes 10 cigarettes a day, and CT angiogram is normal with zero score. That doesn't give you a 2-year warranty, because you continue to smoke. So what is normal now may not be normal after three months. If somebody has bad diabetes, CT angiogram this time shows normal. Well, that doesn't give you a 2-year warranty, because you still have a risk factor, and that too uncontrolled. So these things will act as a confounder. But as a general rule, if you do not have any other major risk factors, if you are doing everything what is advisable in a reasonable fashion, means you are eating reasonably fine, you are reasonably active in your life, and if your CT angio is normal with a zero calcium, at least for 2 years you don't have to worry. It could be for longer than 2 years also, but warranty period means that you have to be absolutely certain. So for absolutely certain, I'd put it as 2 years. But if you are doing right, you are good for many years beyond 2. I can't give you a number because medically that has not been tested, but 2 years is there in the data, so I can at least tell you. So the other question is, it's a long question and it is a specific question. So one thing that I would really suggest you and I would request you is that these discussions that we are having right now, they are very good for general discussion, but please don't expect me to give a specific answer to you for your health condition, because as I said, individual decision making has to be done by interviewing. It cannot be done just as a general. So the reason I'm saying is because this particular question is a specific question. I will read it out, but I can assure you I will not provide a specific answer for a person. So the question is, 2 years passed, I had an uneventful double bypass arterial graft with no post-operative complication. How necessary it is to take metoprolol, bisoprolol, and a clopidogrel aspirin combination? Put a patient 2 away with the former altogether and manage with one anticoagulant. Please suggest a preferable line of management when the EF is good. When should another CAG be deemed essential or necessary? So, sir, I will just tell you a general answer for it. People who had bypass surgery, after that, they are typically put on blood thinners, either an aspirin or a clopidogrel, and sometimes both. It depends upon how bad your disease was, how much of the blockages were, how many grafts were placed, where were they placed, what was the health of the graft, and all those kind of things. But some antiplatelets has to be there, either an aspirin or a clopidogrel, sometimes both. As far as metoprolol, bisoprolol is concerned, both of these drugs are in the same class. So I hope you're not taking both the medicines. Usually we prescribe either a metoprolol or a bisoprolol, but not both. The indication of prescribing this medicine is again individual to you. A lot of patients with blockages, they are on these medicines, and sometimes we take it off also. Whether this medicine should be continued for you particularly, for that only your cardiologist will be able to answer. I do not think it will be fair for me to answer on these kind of an educational platform. The last question, another angiogram. Well, angiograms are always clinically driven. We do not do a routine angiogram just because you had a bypass surgery. So whether you need an angiogram or not depends upon your overall health. And that, again, your cardiologist will be able to decide. There is absolutely no algorithm which says that patient who had bypass surgery, they need to do routine angiogram at 5 or 10 years. There is absolutely no algorithm for routine angiogram. So don't do that. Another question is, I'm doing regular heart checkup for my and my diabetes is under control, age is 41. Heart parameters are good, CT scan. So is CT scan required or not? Well, again, whether CT scan is required to detect blockage or not, Sanjeev sir, that depends upon how much is the suspicion for having blockages for you particularly. A lot of patients with diabetes, they are recommended CT scan based upon their clinical requirement. I can't make a general comment that every patient with diabetes should get a CT scan. Absolutely not. So again, a specific question, I won't be able to answer it for you. But yeah, this is something that you should discuss with your own treating doctor. Another question is, what ECG graph in change are reading? Sir, I'm not able to understand your question. Maybe the language is not correct. Basically, when we do ECG, we are looking for signs of heart attack. Remember, ECG is a electric signature of your heart. It is not a blockage or a function signature of your heart. It's an electric signature of your heart. So we are using electrical signals as a surrogate of identifying blockage or heart muscle damage. I hope I'm able to make it clear. We are using electrical signal on the ECG as a surrogate to identify whether you have blockages or whether you have damage to the heart. When we do that, ECG is very good at picking at damage. That is heart attack. But it is not good at picking blockage, because that blockage, unless it causes heart attack, it doesn't cause any change in the current pattern. And so ECG comes normal. I hope that is what you are asking, but I'm sorry if I got your question wrong. The next question is CT chest scan can detect blockages? No. When you do a CT scan of the chest, that is lungs, you cannot detect blockages in there. There has to be a dedicated CT for the heart. We call it CT cardiac or CT coronary angiogram. That is the one that detects blockage. This CT scan is different than a CT calcium score, which is not an angiogram. It only looks at calcium deposit in the heart and it gives you a score of 0, 1, 2, 10, 100, 300, 500, 1000, something like that. So a CT calcium score, it's a plain CT scan, very simple, and it is used as a risk marker. CT angiogram, on the other hand, is a formal CT scan, and it is done to detect blockages in the heart. CT calcium score will not detect blockages. For that, you need to do CT angiogram. Those are two different tests. CT calcium score is a very simple, straightforward, cheap test. CT angiogram is a proper CT scan, which requires preparation, which requires contrast, which requires a proper way of doing it. But CT chest or CT lungs cannot replace either of the two. Which medicines are used in heart emergencies, sir? That's a very broad question. I don't think I will pass on that. I don't think I'll be able to answer this question to you because there are too many and too specific. If your intention was to understand which medicine you should keep at home in case if you can use for heart emergency, I strongly would suggest not to go in that route. I would suggest better than that, wherever you stay or whatever, look for whichever is the nearest hospital that you have. Keep that in your mind, keep that in your phone or wherever. In case if there is a situation where you think there is a heart emergency, the best thing you can do is bring that patient to the nearest hospital as soon as possible, rather than wasting time in finding which medicine to give and what to do. The best thing is simply bring them to the hospital nearest. It doesn't have to be the fanciest hospital. How do we define the jaw pain? Will it be sharp or dull? So most of the heart attack related pain, they are very dull pain. They typically are not sharp. You are not able to pinpoint exactly where the pain is. Most of the time, the patients, they describe with their palm or with their entire hand rather than their finger. So if there is a pinpoint pain which you can press and feel it, the chances are it's not because of heart. But I must tell you that human body confuses us so many times that even when a cardiologist examines, a lot of times we are able to tell whether this is heart-related pain or not, but sometimes we are not able to. And that is where we rely upon further investigations to identify whether somebody has heart disease or not. So if you have a jaw pain which you cannot attribute to anything else, it is better to get checked out. Don't think that just because it is sharp, it cannot be heart. We have seen enough of heart attacks where the jaw pain is sharp also. So prevention of heart disease, which type of diet will be better in general? Is there any diet plan for general population? Yes, there is diet plan, Manulata. There is diet plan. I don't think I can do justice talking about dietary advice in this limited time period. I would suggest that you spend some time with a general dietitian to go over the diet plan. They are far more versed with diet plans and all those kind of things. If you want a general overview about your diet, you can talk to your cardiologist about it. They can give you an overview, but they can't give you a breakfast, lunch, dinner diet plan. For that, dietitians are better suited. And that is their expertise. Doctors don't have the expertise of giving you diet plan. They can give you an overview, but not a plan. Another question is, Doctor, I'm 30 years old. A few months ago, I was feeling difficulty breathing, loose motions, ended falling unconscious, hit my wardrobe, caused me to have bone injury and blood loss. Went to hospital, BP was 80/50. Why has this happened? I never had anything like that. Karishma, I think this is a major issue. This is something that you should discuss with the treating doctors. Again, I'm sorry, I won't be able to answer specific queries. But if you had blood pressure going down to 80/50, definitely something is wrong. You should get it checked out at your nearest hospital. Bad cholesterol versus triglyceride, which causes heart attack. So, bad cholesterol are the worst. And that too, when you look at cholesterol profile, you will see one element called LDL. LDL is the biggest culprit. Triglyceride can be a culprit if they are very high. But if they are in the borderline range or if they are slightly high, we really don't bother as far as heart disease is concerned. But LDL is very bad. That is in your routine lipid profile. Some labs, they do extended lipid profile or a fancy lipid profile. The two other numbers where you will see there is one is called ApoB, and the third one will be called LPA. So three bad cholesterol elements. One is LDL, that is available in all the cholesterol profiles, and the other two which are available only when you ask for it, and one is ApoB and the other one is LPA. Triglyceride, we don't pay that much attention unless they are very high. Is atorvastatin lifesaver in attack situation? Absolutely not. We give atorvastatin at the time of attack, but it is not a lifesaver. It is part of the treatment. Remember, when we are treating with heart attack, we are giving lot of treatment, lot of medications. Not one of them can be considered lifesaver. They all work in congruence with each other. So just because we are giving atorvastatin in heart attack, which we do, that is not a lifesaver. That is part of the life-saving strategy. Beta blockers used in heart disease. Yes, beta blockers are used in heart disease and heart attack cases. We all use it in heart attack also. We use beta blockers. That is one of the many medicines that we use along with atorvastatin. In some heart attack situations, we decide not to give beta blocker up until some other point. All of those decisions are based upon how the patient is doing at that particular moment. What is the blood pressure? What is the heart rate? How much is the pumping power left? How big is the damage? How many blockages are there, and so on and so forth. But yes, beta blocker is one of the cornerstone of heart attack management, but not every patient receives it. It is individualized to individual needs. Will thyroid patient get a heart attack? So, Lali, so far, we do not have an evidence that thyroid abnormality by itself will cause a heart attack. No, but people who have overactive thyroid gland, so what we call it as hyperthyroidism, they sometimes can race your heart so fast that your heart may not be able to keep up and cause a minor heart attack or a major heart attack for that matter. But thyroid disease by itself does not cause blockages. Hypothyroid, which is the most common state where your thyroid is underactive, that doesn't cause a heart attack. It can cause heart dysfunction. It can cause muscle dysfunction, but not a heart attack, not a blockages. Hyperthyroid, where your thyroid is too active or overactive, there it can race your heart very fast and trigger a heart attack, but it will not cause blockage. It's not a cause of blockage. You can't treat thyroid disease and hope your blockages gets better. No, that's not going to happen. What is aspirin? Aspirin reduces blood clotting. No, sir. No, Rajiv, sir. Aspirin is a blood thinner. I read you wrong. Does aspirin reduce blood clotting? Yes, it does reduce blood clotting. It is a blood thinner. It's a very weak blood thinner, but that is all we need for blockages. For heart blockages, we need weak blood thinners. We don't need strong blood thinners. So aspirin reduces blood clotting, but it cannot reduce major blood clotting. So let's say if somebody had a blood clot in their legs, aspirin is too weak to handle that. But heart attack, those blood clots are very small and aspirin can handle those, but not blood clot elsewhere. If you have blood clot in the legs, in your lungs, in your brain or whatnot, you may need stronger blood thinner. Aspirin is very weak there. Is there a golden hour during heart attack? Yes, there is a golden hour. So most of the time, what we say is the early you intervene in heart attack, better it is. And again, I tell that do not waste time finding medicines by family members. It doesn't work unless your doctor has prescribed you medications to take during emergency. It doesn't work out where you had the first emergency in your house and you are wasting time in giving medicines and whatnot. If you feel there is something wrong and if you think heart may be an issue, rather than wasting time in finding and giving medications, the best thing is get them to the nearest hospital. That is the best you are going to do. No amount of atorvastatin and clopidogrel is going to save that patient. Remember, these are all a part of the treatment. They are not the treatment by themselves. So if somebody has a heart attack, no matter how much atorvastatin or clopidogrel you give at home, that won't be sufficient to save that person. So the only thing that will work is hospital. Get them to the nearest hospital. My lipoprotein A is high. Lipoprotein, by that I mean LPA is high, LDL is 138. All others are okay. Do I have to take tablets? Dr. Bharti, a lot of it again depends upon your overall risk profile. If you are at a higher risk subset, then LDL of 138 is high and lipoprotein A of more than 35 is high. If you are in a low risk subset, then I won't put you on a medication. Now, which risk subset you are on, I don't know. For that, I will have to interview you and see all the other parameters. So the cutoffs for cholesterol are highly individualized for an individual person. And for that, we have to interview thoroughly and see what else is going on. So to answer your question, whether you take medicine or not is based upon your risk profile. My LDL cholesterol is normal now, which is higher 1 year ago. Should I be worried about it? Again, sir, LDL cholesterol is just one aspect of your overall health. If your LDL cholesterol is perfectly fine, but your overall health is not good, then you need to be worried about it. If your LDL cholesterol is normal, but your calcium score is 100, you should be worried about it. If your LDL cholesterol is normal, but you have too much of unhealthy oil and carbohydrates in your diet and you are sedentary in your life, well, you should be worried about it. So I don't think LDL cholesterol alone can tell you whether you should be worried or not. That is just one aspect of it. Is nitroglycerin used for heart attack? Yes, it is used for heart attacks. It is used to reduce the amount of damage. It won't treat the heart attack by itself. Sometimes we give nitroglycerin to patients to use it as and when needed. But again, if it is a first time emergency happening in a person, don't waste time in nitroglycerin, don't waste time in atorvastatin, just don't do anything. Get to the nearest hospital. Let the doctors do their job. Any minute then you waste in getting the nitroglycerin can determine whether the person will survive that heart attack or not. Only aspirin reduces blood clotting, not in combination used. Well, there are multiple medicines that we use to reduce blood clotting. Aspirin is one of them. Ticagrelor is another one. Clopidogrel is another one. A lot of the time, these medicines are combined with cholesterol medications. So there are a lot of these medicines, and you can use it in combination with lot others. Any person who has got major blockage, they will be put on one of these blood thinners or antiplatelets. Which one? That will depend upon that particular patient profile. Sometimes we give more than one. Sometimes we give aspirin plus clopidogrel. Sometimes we give a higher dose. Sometimes we give a lower dose. All of that depends upon what is the individual need at that point. And yes, we give it in combination at times with cholesterol medications. I have chronic GERD and I'm CAD. My age is 71. I could use clopidogrel for last 10 years, but could not take for the last 2 years due to irritation of the stomach. Despite antacids, please suggest any lower dose or any other alternative method. Sir, I will tell you, clopidogrel by itself does not cause stomach irritation. Aspirin does, but clopidogrel does not. So while taking clopidogrel, if you are having stomach irritation, I can assure you that is not because of clopidogrel. There could be something else going on in your stomach. Having said that, whether you can use alternative medications or not, there are alternative medications. You should talk to your doctor about it. 75 milligrams of clopidogrel is the lowest dose possible. We don't go lower than that. There is absolutely no medical benefit of taking clopidogrel lower than 75 milligrams. Which one you should take? I think you should talk to your doctor about it. But clopidogrel as a general will not cause stomach irritation. TMT, 2D echo and ECG were normal in September, and again, normal ECG checked in February. What, according to you, is the best time to get checked next time? I would say, Mr. Vasavi Reddy, there is absolutely no reason for you to keep checking your ECG and echo. You have checked it once, it looks fine. After that, you make it a point of meeting a cardiologist every year earlier if you have any problem, and let the cardiologist decide whether you need investigations or not. Simply just doing repeat investigations every year, that's not a good strategy. One of the time that investigation will show some erroneous finding, and then you will be chasing that erroneous finding. So doing it once was a good idea. Don't keep chasing it. Let your doctor decide when you should get the next one. What are non-cardiac chest pain? I'm having cervical lordosis and get pain in the neck area. So yeah, cervical lordosis, cervical spondylosis. Remember, chest has got skin, it has got muscles, bone, nerves. You have got food pipe, you have got lungs, you have got all other parameters there. So pain can arise from anywhere. Wherever there is a skin, you can get a pain. Wherever there is bone, you can get pain. Muscles can give you pain. Nerves can give you pain. So just because you have a nerve irritation on the chest giving you pain, that doesn't mean you have a heart attack. Pain can be present anywhere. Cervical lordosis or cervical spondylosis is a very common cause of pain because that nerve gets irritated and it gets radiated to the chest. So not all chest pains are heart attack. When you have pain in the chest, please get it evaluated. If it is not because of heart, there could be multiple other reasons, the ones that I mentioned you about. And then the treatment is tailored towards that particular entity. You can forget heart at that point once everything is normal. How to bring down BP? My husband is 62. Well, ma'am, to bring down blood pressure, there are 3 key elements, I would say. Number 1, to reduce your salt intake down. Number 2, add physical activity in your life. And number 3, you may have to take some medications in that particular order, which means you first reduce your salt intake. Second, add some exercise, cut down your weight. And even with all of that, your blood pressure is still high, then you should be on medication. There is no point staying at high blood pressure for years, thinking that someday you will change your lifestyle and your blood pressure will go down. That's not a good idea. Bring your blood pressure down. Even if you have to take medication, that's a good idea. From last 2 months, I'm having left-sided hand and leg pain and shoulder blade pain. Is there any problem? Suggest medicine. Manjula ma'am, I won't be able to suggest medicine to you. I cannot make any specific treatment here. I can give you general advice if you have any general question for me. But for your particular pain, I would suggest you please see a local doctor or a cardiologist around you and let them take a call. I wouldn't consider myself equipped enough that on a webinar I will be able to answer specific questions. So I believe that is the end of questions on the chat box. We are past 12. Maybe we can take a last minute question. Or we'll close the session. Moderators, you can take over from here. Okay, if there are no other questions, maybe it's a closing time. Anyone in the moderate? Anyone who is moderated? Okay. All right. Thank you all for your patient listening. I hope I was able to add at least some value to your 1 hour that you were with me. And I hope I was able to answer few of the questions. I'm sorry I didn't address the specific questions that is not within the realm of a webinar. Not only it is illegal, but I do not think that is the correct way of doing it. If you do need specific questions answered, I would suggest please talk to your treating doctor or a nearby cardiologist. They will provide you far better answer. And if you need any particular specific treatment, second opinion and whatnot, you can contact Easy Treatment. They will be able to guide you which doctor to get, where to go, and all this kind of things. So thank you again. At this point, I will close the session.
Thank you to all the participants who attend our webinar on preventing early heart attack. If you require any further assistance, treatment, or healthcare suggestions regarding cardio or any other health issue as well, please do not hesitate to contact us. Our number is 96000016661766. Our dedicated team is here to provide you with the proper support and guidance you need. Once again, thank you for all joining today. We look forward to serving you and continue our journey towards better health together. And one more important thing we are announcing: who are the participants, who are the attended here today, we have some exclusive offers for them. If you will book the appointment with us for the doctor, you will get the 50% off on doctor consultations and 20% off on lab test as well. But the offer is valid for today itself for up to 7 p.m. So you can contact on the same number, or you can also WhatsApp us on the same number. So we will be there. We will guide you. Appointment can be scheduled, but the offer will be till for today itself up to 7 p.m. And the another offers also you have. If you book a consultation with us through the Easy Treatment, so you will get additional 15% off our combined cardiac test list also. So don't miss an opportunity. Just grab the special offer what we are announcing. So thank you again, all the attendees who have joined today and asked so many questions, and you have made the session interactive. And all the recorded session also we will provide on our YouTube channel. I will share the YouTube link on the chat. You can go and you can check our previous webinar details also, and stay tuned. So we'll further this recorded session also you will get further. Thank you so much.